continue right where we left off yesterday, learning about these different tests and procedures. And next thing we're going to learn about is a myelogram. And basically, it's like the other studies, but what it's looking for is it's wanting to look for abnormalities of the spinal cord and all of the tiny little nerves in the spine. Okay, so that's what you'd want to know, a myelogram. So if your patient's got to go in for a myelogram, let me let you know, it's a scary procedure because they have to stick and I think I've actually got the picture. Yeah, see, that's your spine. That's the needle they put in to get the dye in there. And it's a scary procedure. I've had one done because of, well, I've had a couple. I've had one after my car wreck, and they're seeing how bad of degeneration that I had in my disc, and also for multiple sclerosis. So that's not a pleasant experience, okay? So you don't want to freak your patients out and just tell them that, that they, they're able to, give the patient medication to help numb it, and that it's a routinely done procedure. It usually will take about 30 to 60 minutes. And then after that, they usually follow up right afterwards with a CAT scan. All right. So a myelogram looks for abnormalities of the spinal cord and all of its nerves. Okay. And then, like I said, that's a picture. And that makes my, and you ladies, you might know what I'm talking about, because I've heard a lot of women say this. If you had an epidural, it might have been 15 years ago, you can still sometimes feel that pain right there. I still feel the pain from the different procedures I had. So including my epidurals. All right, arth, that's a joint, right? So this is or a recording or an imaging of a joint. And it can be any joint. Right here, what are we looking at? We're looking at a shoulder, right? So this person, they're wanting to see, and you can see that this, they've got some type of injection going in here to light it up. And it's usually done with fluoroscopy. All right, so that's the way to light up the surrounding areas. Any questions about that? So arthroscopy is when they go in and they do, they actually make the little punctures, and they go in and they clean it out, or they look for something. So it's a surgical procedure. So I spoke incorrectly. This is an arthrogram, and it's just a picture. And then an angiogram. And I really thought this picture was pretty cool, because this image is showing you an angioma, which is basically, it's a benign growth. So it means it's not cancerous, but this is how the thumbs and the veins should look. It should be nice and free. Do you see that the mass here, and how that the vessels are just completely entangled, and it doesn't look like she's got or he's got much blood flow at all to this area here because of this. So, and that's what an angiogram does. It is able to, with using contrast in the medium, to go in there and to visualize the inside of blood vessels and the organs, particularly with the heart. And I have a small video I'm going to post to Teams showing an angiogram for them looking at a patient with a possible MI. And so it's very interesting. They usually go in through the growing, and I've heard it sometimes in the arm as well. But all the ones that I witnessed were in through the growing, and they do a little lead and a camera, and it's really cool, especially when they inject and how everything just lights up. You can go from seeing, yeah, a little bit to then just being like, wow, I can see every structure. I can see all of the vessels. It's really, really cool. So make sure you catch that video. All right, the next thing we'll talk about is what's called a barium. Hold on, I'm getting feedback. A barium enema is, we talked about barium, that it's one of the contrasts that we use. And now an enema, in case you didn't know, is usually where something's stuck up rectally and solutions injected into the rectum, so the lower GI. Now they're doing this because we want to light up that specific area, and a barium enema works without having to put it through all of the body, expose all of the body. This is very helpful for the image like that I have here. This is called Hirschsprung's syndrome. And what it is we see this in newborns and small babies, and we should have the intestines not the size, and then this should continue to flow. But you see right here, it's not. And so there has to be surgical interaction that's done for these babies, or they'll never, it could be lethal, it could be life-threatening, and they have a lifelong complications and stuff like that. So when they suspect something like that, they'll do a lower GI using a barium enema. Enema, and this is showing you like a little supply kit of what we see when we might have an enema kit, and don't count it out. You might end up, if you work for a GI doctor, you might be involved in an enema or two. Just letting you know. And what an enema will do, like I said, there's the tubing and the little the tool tip that goes into the rectum, and the bag is usually hung, and then the solution is squeezed in, and sometimes they have certain like little devices that help slowly administer it. That's one way. And then another way that they can administer these medications is through rectal suppositories. And I'm sure most of us are familiar with that. When you were a little kid, I know if you ever got the flu, sometimes the doctor would call in medication. Your mom would have to stick it in your butt because of, you were vomiting, you couldn't keep things down, that kind of stuff. And it's beneficial for suppository because, like I said, it's just affecting that specific area. Now, it does eventually, whatever we put in rectally to a patient does get dissolved or involved into the bloodstream, because this might be surprising, but the rectal and the rectum, the area around that area, is highly vascular, and it can actually absorb really well. So it is a good spot for medications, and when we're needing. Some of my seizure patients, pediatric seizure patients, they would have suppositories that their mother, because you couldn't give them a pill, all right, but so there were rectal ones because it was quick acting. What our patient would want to know is that they have a time. I know this says 4 p.m. the day before the x-ray, but basically that's going to be depending on A, what time is the patient's procedure, B, how long does the doctor want the, everything cleared out. So each doctor will tell you, okay, tell Miss Jones she's got to go, you know, uh, do this enema or this suppository 6 to 12 hours before her procedure. Whatever, the doctor tells you, that's what we would relay. All right, the next thing. Go ahead.
So for the enema, is that done in the office or was that done at home?
Both.
Okay.
Sometimes the doctor will write a prescription and they'll pick it up and they'll do the enema at home. Sometimes there's even over-counter enemas called fleet enemas, and they're just in a little plastic bottle with a nozzle, and you squeeze it up in there, and uh, uh, some people use them as like a detoxifying colon type of cleansing kind of thing. But other times, yeah, it might be done in the in the office. I actually had one time a student come back and say, Miss Scalf, you did not tell us about impactions. And I said, oops. And an impaction happens sometimes a lot of times in the elderly, because as we get older, our GI system starts to slow down. A lot of times they're on narcotics because they've got pain and issues, and that slows down their GI tract and their system, and they don't have enough fiber, so they get built up hard, impacted poop. And one of the procedures to do this when the medications and stuff doesn't work it's an in-office procedure, and the patient's on all fours, and there's like these towels and buckets, and you have to put the tube, and she was just like, she goes, I am scarred. And I felt so bad. And she said that the person, that they were doing the procedure, she was, I guess, funny and was joking along with it, even because she was a little old lady or whatever. But she said it was just still, she said, so be prepared. That is possible. Like I said, as an MA, you never know what you're going to come across or you're going to see. Is it going to be as crazy as somebody working in an ER? No. Is it going to be as crazy as a paramedic? No. But sometimes there are some crazy things that happen. So, and you have to be prepared for them, and always be professional. Patients are going to fart on you. It's going to happen. If you work for an OB-GYN and you got somebody in the stirrups, it's going to happen. And you've got to try to stay professional and that kind of stuff. So be fluid. Roll with the moment, and always try to remain professional. All right, back to the topic on hand. Our next one, broncho. So what is this? We just learned this. We talked about the trachea leads to the the right and left bronchus, and it goes through into the bronchioles. Check this out. We can even see the imaging through here. Somebody's got real bad feedback. They got to mute their mic. And from what I understand, this picture was taken of a patient with cystic fibrosis. The bronchogram allows the doctor to do one of two things: to make a certain area stick out by filling the surrounding area with fluid, with air, and sometimes that they'll use contrast as well. If Another thing they do with bronchograms, because while they're looking, is that procedure I was telling y'all about. I think it was y'all about cystic fibrosis, where they can actually go in with like a tiny little vacuum and relieve the airways, the bronchioles and stuff of mucus. And I know they use a bronchiogram to guide them through that procedure. So it's used for multiple purposes. And it can also be used just to check and make sure how the progression of somebody's lung condition. I know that with COVID, this is something that they're routinely doing as well because of the damage that's caused to the lungs from COVID. All right, so coli is what? Gallbladder, and then gram. So we're looking at the picture. Let's look at this picture. Here we have a really inflamed, large gallbladder and some pretty big stones. And I say it's inflamed and large because usually it'd probably be about half that size. We know that a cholecystogram is going to give us an image and allow us to view not only the gallbladder, but that biliary tree, the branches off of it. And as far as that leads to the pancreas, it leads to the liver. So that whole area. And it's very helpful with decisions, and especially trying to find out, because sometimes what can happen is those stones in the gallbladder can sometimes leave the gallbladder. And if one of them gets stuck in that biliary circuit, it can cause massive issues like liver failure, like when I'm telling you massive issues, like serious big time problems. So sometimes they'll do this just to make sure, that that's not the case, that no stones have escaped or moved or anything like that. All right. And then a CT scan. So if you've ever had one of these, they are not as bad as an MRI. They're actually a lot quieter, and you don't have to go all the way in the tunnel. It's a quick little. It's not as intimidating or claustrophobic as like some people feel MRIs are. And what it does is a really quick inside image, and it's a pretty good image for how fast it is, of the organs and the parts and everything that they want to visualize. It's really done a lot with after car accidents or falls or head injuries. Check for concussions. It's done with if they're think maybe appendicitis or something like that. So it's a really quick way to get a look at what we're trying to view. All right. And where's my picture? We'll come back. I've actually got a really cool video with the CT that I'm going to post. All right, the next thing is called, we're going to always abbreviate it IVP, but it stands for intravenous pyelogram. This term right here, you wonder, why in God's green earth does it have anything to do with a kidney? But that's what it is in reference to. And you, like my mother had pyelonephritis. And so you'll see that PYE associated with kidneys, and it's got to go back something Greek, Latin, or something like that. So when you hear this in IVP, you're going to know they're wanting to visualize in depth because they're giving them a contrast, and they're wanting to check out and see not only the kidney, and this, like I said, this is a great picture because right here you can see the full kidney, you can see the renal pelvis, you can even see all of the additional blood supply and stuff through or and around the kidney. And on this image here, it's really nice because this is the ureter. And you can see it, and you can see how it leads to the bladder. So it's excellent. This picture right here, this kidney over here ain't doing so hot because we've got a kidney with kidney stones, and here's a stone that is blocked. And do you see how you cannot visualize the ureter here? And that's because it's blocking flow. So this is what the IVP does. It gives us a really in-depth image of the kidneys, the ureter, the bladder, but in detail. Because there's another test called a KUB. That's kidneys, ureter, and bladder, right? And it's just a real basic image. This is more in-depth because the contrast lights it up, gives us ability to see better. All right, an ultrasound, a lot of times we'll hear it referred to as a sonogram. All right, these procedures use really high frequencies. We can't hear them. They're not heard, with the human ear, but an ultrasound uses it, and it's basically like it delivers the sound, and whatever it comes across, it pings back. And the computer that it's attached to is able to decipher each different sound wave, ping back, and develop an image by what it sees, by what it hears. And so to me, I think it's amazing, and they've been using ultrasound for a while as well. They use it in ocean exploration and things like that. So, but for medical, it's a modern medicine and it gives us such a great ability to be able to view an organ or a baby or something without having to cut the patient open. Because in the old days, if somebody was having pain and it wouldn't go away, that's what they did. It was called exploratory surgery. And that means they just cut you open and fished around till they found what was wrong. No lie. I kid you not there, guys. So ultrasounds help with that. Ultrasounds are used not only for just babies, but looking at, say, ovaries or the fallopian tubes or the epididymis for men. There's the prostate. There's all kinds of ultrasounds of the gallbladder and ultrasounds of the pancreas. And so, there's just many, many different reasons that they use them because it gives them a quick, easy way to determine if there's something that they see that's abnormal. And also, when you're pregnant, it's wonderful because you get to see inside and see the little toes and the little hands and nosies that you're making. Now, an MRI, this is where there are a lot of rules that we're going to have to explain to our patient with MRIs. And there's a lot of questions. And an MRI stands for magnetic resonance image. That right there tells us they are using big, gigantic magnets. And so the magnetic, so the key there is if our patient has anything metal on them or in them, these magnetic forces can literally pull them out. There's been freak accidents and stuff like that where people's fillings have come out, old-fashioned fillings and things like that. Somebody didn't tell somebody that their nipples were pierced and it ripped. you know not a fun thing, right? So we always make sure our patients are very informed that everything that is any type of metal be taken or removed. And if they have a pacemaker, that needs to be, somebody needs to say, hey, that's one of the questions they ask. Do you have a pacemaker? Do you have any implanted devices? Do you have, they have like insulin pump or the little devices they place in the back for pain management and stuff like that. All of those have to be noted. So you have to really make sure that you thoroughly explain to your patient why this is important. An MRI is going to give us the clearest, most accurate view of the inside of our patient that we're able to get as of right now. We can, with certain contrast and dyes and different things, they're able to get, now this is a, basic, but I mean, look, you can see the folds in the brain, you can see medulla, you can see the sinus cavities, the tongue. I mean, it's like really in depth. I've seen a lot of my brain more than most people have, and when you get used to viewing these images and you see them a lot, you can spot, oh, what is the, something's here, like if there was something, oh, that's a mass or this or that, or this shouldn't be here, that's abnormal. And MRIs are very helpful, especially when contrast is used as well, because contrast, just like with an angiogram, they can do that with the brain and light up all the blood vessels and everything inside the brain. Look for maybe an aneurysm or